Like 69 years male complains of the severe radicular pain for more than 1 year, left more than the right, sometimes it is bilateral same. He is non-diabetic but hypertensive. The walking distance is grossly reduced less than 100 to 200 meters. Not able to stand at a stretch more than 10 to 15 minutes. It is L4-L5 severe lumbar canal stenosis, bilateral lateral canal stenosis and foraminal stenosis. There is grade 1 spondylolisthesis. We are approaching from the left side, it is bilateral symmetrical. This is the left approach. This is the L4 lamina, L5 lamina, facet and the spinous process. We are approaching at the spinolaminar junction. My kerison is 3 mm 45 degree. I am trying to introduce my kerison. It is very tight canal, not able to negotiate. Severe tight canal. We are operating with the help of the 3D 4K endospine system, Storch, Germany. The first bite usually I used to take at the spinolaminar junction. This is the spinous process and lamina. So spinolaminar junction is the ideal position to start with, because here it is the dura, it is a little bit away. Actually, 45. I am trying to detach the ligamentum flavum or yellow ligament cranially. Now it is detaching. The hypertrophic ligamentum flavum is one of the major cause for the lumbar canal stenosis. Gradually we are coming to the lateral aspect of the lamina, and superior lateral aspect of the lamina is the highest point of the attachment of the ligamentum flavum. The ligamentum flavum is attached more cranially here. The medial aspect of hypertrophic portions of the lamina. The superficial layer of the ligamentum flavum, which is attached superficial to the ligament inferior lamina or caudal lamina. So we have got the two layer of the ligamentum flavum. The superficial layer is attached posterior to the or superficial to the lamina, inferior lamina, that I am detaching now. and removing, which is very much hypertrophied. So this is the deep layer of the ligamentum flavum, which is attached at the superior border of the inferior lamina. This is the medial aspect of the IAP, that is called inferior articular process. This is very much hypertrophied. This is the osteophytes. Big osteophyte or huge osteophytes are here from the IAP. Patient is 69 years. IAP is the inferior articular process of the facet joint of the superior vertebra. It is L4-L5 level, so this is the L4 vertebra, the inferior articular process of the L4 vertebra. And this is the SAP, the superior articular process of the L5 vertebra. This is also very much hypertrophied. This is the deep layer of the ligamentum flavum. This person. Pretty. So I am putting a patty cranially now to protect my dura. And this is the caudal patty also to protect the dura. So this is the dura or the spinal cord. Now I am removing a bit of the inferior lamina, the superior aspect. This is the foramen, rather it is called foraminotomy. Foraminotomy is most important to reduce the pressure on the nerve root. So de-roofing of the foramen. टेबल टिल्ट करो. So discursive. Spatula. So I am trying to go to the midline now. I'm just just changing my petty now. Very, very tight canal, even the petty is not negotiable. So I am approaching to the midline now. This is the overhanging hypertrophic spinous process. Sorry. This spinous process is very long from here, and we are just trimming a bit of the bone, maybe 2-3 millimeter, which is very much hypertrophied, and this is the overhanging hypertrophied part of the spinous process. We are just trimming a bit so that the spinous process hypertrophic pressure which was compressing to the spinal cord, that was to be removed. The spinal cord will be free, the canal will be free. This cursor. Okay, now we have crossed the midline. 45. We have crossed the midline. We are going to the opposite side now. This is the opposite side infralamina. These are all hypertrophied portions of the ligamentum flavum. This cursor. Ready? We are trying to negotiate the petty cranially at the shoulder of the nerve root. Of the opposite side, there is the right side. We are approaching from the left side. Very, very tight canal. The visualization will be better. So this is the opposite side hypertrophic facet along with the this. Spatula. So very tight canal, even the spatula is not negotiable. This is my nerve root. These are hypertrophic portions of the facet of the opposite side. This. Spatula. So this is my nerve root here, very much hypertrophic. This is a nerve root, very much hypertrophic facet, dispersive. Choto peti. Choto peti. We are trying to put the smaller peti because it is very tight canal. The normal peti is not negotiable. So smaller peti at the shoulder of the nerve root. Now this is my nerve root and this is the foramen. 45, 2 mm. Yes, this is the hypertrophic portions of the facet. Sorry, SAP, superior articular process. Now we have entered into the foramen of the opposite side, and this is the foraminotomy. Yes, deroofing of the foramen of the opposite side. Yes. Photo. So this is the nerve root of the opposite side. Spatula. This is the nerve root of the opposite side. It is at the foramen. Now very much clear here. Up to the foramen we have dissected. We have not removed the midline structure at all, so that the visualization is a little bit compromised, but still we can approach, and foramen anatomy done on the opposite side. Nerve root is clear. Left. लैब जल रहा है। So to maintain the hemostasis, we are just putting a bit of gel out there. Table tilt, petty, modgo. So as you have decompressed the nerve root of the opposite side, thou, that is the right side. Now we come back to the left side again, and this is my cranial petty, disperser. These are the soft tissue hypertrophic synovium of the facet joint, and this is my SAP, this is the foramen. Just I want to see the nerve root here, and it should be decompressed up to the foramen. And this is my caudal petty at the left side. So my petty is at the axilla. The nerve root is very clear here. This is my nerve root, very tight. The canal is very tight. Now 2 mm. Camera approach. The disperser. छोटा पेटी. So nerve root is now pushed medially. This is my nerve root. This is the dura, and I will try to remove a bit of the bone here. This is the hypertrophic portions of the superior articular process of the L5 vertebra. So my foraminotomy almost complete now. Nerve root is clear in front of me up to the foramen. So nerve root is decompressed completely up to the foramen, mobile. Spatula. I am putting the nerve root little anterior, so that the nerve root will be post medially, and I got a little more space here. There is a pseudo disc, one grade 1 listhesis. I am planning to just decompress a bit of the disc, otherwise I will not going to remove the much of the disc here, because it is a grade 1 spondylolisthesis. Now my nerve root is protecting to the nerve root retractor is protecting my nerve root. I am putting the 11 number blade for annulotomy. My nerve root is removed. Nerve root retractor was protecting the nerve root. So now the projected portions of the disc is reduced or shrinked. Not of the much of the disc here. Saline. So now we will irrigate the disc space with normal saline and gentamicin. The free flow of the saline indicates there is no more free fragments inside the disc space. A lot of free fragments that was there inside is coming out with the disc percept. With the pressure of the normal saline, these are the free fragments that automatically pushed out with the pressure of the normal saline. Disc percept. Saline. Saline. Disc. Like disc percept. The camera approach. ना ना बर्गर पानी पेटी disperser